Fracture and dislocations of the elbow. The elbow is a complex hinge joint comprised of three articulations: the radiocapitellar joint, the ulnohumeral joint, and the proximal radioulnar joint. The series of interactions between the joints allow for elbow flexion and extension and forearm pronation and supination. The stability of the elbow is conferred by both dynamic and static stabilizers. Dynamic stabilizers are muscle tendon units, where static stabilizers are bones and ligaments. The column theory of elbow stability focuses on four columns: the anterior column, which is comprised of the coronoid process, brachialis muscle, and anterior joint capsule; the medial column, which is comprised of the medial collateral ligament, coronoid process, and medial condyle and epicondyle; the posterior column, which is comprised of the olecranon process, triceps muscle, and posterior aspect of the joint capsule; and the lateral column, which is comprised of the radial head, capitellum, and lateral collateral ligament complex. Another way to look at elbow stability is through the lens of the fortress theory. In this viewpoint, the ulnohumeral joint is the primary bony stabilizing unit of the elbow and is complemented by the medial collateral ligament, which provides valgus stability, and the lateral collateral ligament, which provides varus stability. Note that the ulnohumeral joint confers stability at less than 20 degrees of elbow flexion and at greater than 120 degrees of elbow flexion. The MCL and LCL both confer stability through the elbow arc of motion from 20 degrees through 120 degrees of flexion. The secondary elbow stabilizers are the radiocapitellar articulation, the common extensor tendon, which provides valgus stability, and the common flexor pronator tendon, which provides varus stability. A closer look at elbow anatomy reveals the structures that comprise the medial ulnar collateral ligament complex and the lateral collateral ligament complex. Medially, the anterior bundle, also known as the medial ulnar collateral ligament, or MUCL, is the primary valgus stabilizer. It has an anterior band which is tight in extension and lax in flexion, and a posterior band which is relaxed in extension and tight in flexion. The anterior bundle inserts onto the sublime tubercle of the coronoid process. There is a separate posterior bundle and a transverse ligament. The lateral collateral ligament complex is comprised of the radial collateral ligament, the annular ligament, and the lateral ulnar collateral ligament, and provides varus stability to the elbow. Elbow stability is disrupted when there are fractures of the distal humerus or proximal ulna and/or radius that involve any of the four columns we have previously discussed. The AO-OTA fracture classification adequately characterizes the fracture patterns seen in the distal humerus and proximal ulna and radius. There is a separate lecture on distal humerus fractures, so I will not go into much detail on this topic during this lecture. Briefly, distal humerus fractures are characterized as 13-A for extra-articular fractures, 13-B for partial articular fractures, and 13-C for complete articular fractures. In the AO-OTA fracture classification scheme, proximal ulna fractures are classified as 21-A for extra-articular fractures of the ulna and/or radial head, 21-B for articular fractures of either the ulna or radial head, and 21-C for articular fractures of both the ulna and radial head. The radial head, an important secondary stabilizer to valgus stress, is well characterized by the Mason classification system. Type 1 fractures are non-displaced. Type 2 fractures are displaced partial articular fractures. Type 3 fractures are comminuted complete articular. Type 4 fractures, which are a Johnson modification of the Mason classification, are radial head fractures with an associated ulnohumeral dislocation. Coronoid fractures, which involve the anterior column of the elbow, are well characterized by the Reagan and Morey classification scheme. Type 1 fractures are avulsion fractures of the tip of the coronoid process. Type 2 fractures involve less than 50% of the coronoid process height. And Type 3 fractures involve greater than 50% of the coronoid process height. O'Driscoll has further classified coronoid fractures. Type A fractures involve the coronoid tip and are either less than or greater than 2 millimeters in size. Type B fractures involve the anteromedial facet and are further subclassified into three subtypes: anteromedial rim, rim plus tip, and rim and tip plus the sublime tubercle. Type C fractures are basal fractures that are subdivided into two groups: those that involve the coronoid body and base, and those that are transolecranon basal coronoid fractures. Olecranon fractures involve fractures proximal to or involving the coronoid process. The Mayo elbow classification is simple. Mayo type 1 fractures are undisplaced olecranon fractures. Mayo type 2 fractures are displaced olecranon fractures that are either subclass A non-comminuted or subclass B comminuted. Mayo type 3 olecranon fractures describe displaced olecranon fractures with accompanying lesions of instability, i.e. dislocations. These are also known as transolecranon fracture dislocations and have a worse overall prognosis due to the bony and ligamentous injury. Due to the constrained nature of the elbow joint, failure of the primary and/or secondary stabilizers occurs in reproducible mechanisms. Anteromedial facet fractures result from forearm pronation, varus stress, and axial loading of the elbow joint. Medial elbow dislocations result from valgus stress combined with axial loading of the elbow joint. Posterolateral elbow dislocations result from forearm supination, valgus stress, and axial loading of the elbow joint. Plain radiographs of the injured elbow can oftentimes demonstrate gross instability. The X-ray on the left, labeled A, shows a concentrically reduced ulnohumeral joint, whereas the elbow on the right, labeled B, shows a posterior type dislocation of the elbow. In the concentrically reduced elbow, the lateral radiograph demonstrates a concentric ulnohumeral joint and collinearity of a line bisecting the radial head and capitellum. In the dislocated or subluxed elbow, there is loss of congruency of the ulnohumeral joint and loss of collinearity of the radiocapitellar line. Prior to reducing the dislocated elbow, it is paramount to document a thorough distal neurovascular exam. Next, close reduction is attempted, with the picture here demonstrating an easy technique to achieve reduction. Here, axial traction is applied to the forearm while in a semi-extended position by the physician labeled B. Simultaneously, the physician gradually flexes the injured elbow while applying a dorsal moment to the forearm and levering the ulna back into the articulation with the trochlea. After the elbow is reduced, it is necessary to range the elbow and document the stable range of motion. If the elbow is grossly stable, splint it at 90 degrees. To aid in stability, if the elbow dislocates posterolaterally, splinting and pronation can lengthen the extensor wad, making it more firm and thereby increasing stability of the joint. If the elbow dislocates posteromedially, then supination will lengthen the flexor pronator musculotendinous unit, thereby making it more tight and increasing the stability of the reduction. Post-reduction protocol for elbow dislocations are generally as follows. The elbow should remain in a long arm splint for 1 to 2 weeks. Repeat an X-ray at the first office visit to ensure the elbow is still concentrically reduced. If the elbow is still reduced, then convert the patient to a hinged elbow brace unlocked through the stable range of motion. Allow early active and active assist range of motion through the stable range of motion. Also, allow forearm pronation and supination as well as grip strengthening to prevent stiffness and muscle atrophy. By 4 to 6 weeks, start a graduated flexion extension and pronation supination strengthening program. The hinged elbow brace can be discontinued when the patient demonstrates increased strength and range of motion with minimal elbow pain, usually by 6 to 8 weeks. If, however, an elbow continues to sublux or dislocate after attempted reduction, then operative stabilization of the elbow joint is required to ensure a stable and concentric arc of motion. In this scenario, repair of the collateral ligaments are performed, which can be done through either a midline posterior approach and by raising medial and lateral flaps or making separate medial and/or lateral incisions. Laterally, muscular intervals are developed through either the ECU Ankenius, also known as the Coker approach, ECRB and EDC, also known as the Kaplan approach, or through an EDC split. Medially, muscular intervals are developed through the brachialis and triceps muscles proximally and between the brachialis and pronator teres muscles distally. After repair of the ligament, if the elbow continues to be unstable, then an external fixator should be applied. Depending on the severity of the injury, the X-fix can be static, which are reserved for severe soft tissue injuries, or can be hinged. Range of motion in a hinged fixator can be immediate or delayed, and again depends on the severity of the soft tissue injury. Application of an external fixator around the elbow requires knowledge of the safe zones for Shanspin's placement. 4 mm Shanspins are sufficient to ensure stability and prolonged fixation in both the humerus and ulna. Based on axial anatomy and location of neurovascular structures, the safe zone for the distal humerus is the anterolateral quadrant. Note that the radial nerve exits the posterior compartment and enters the lateral compartment through the lateral intermuscular septum between the brachialis and brachioradialis approximately 7.5 centimeters from the distal articular surface. Due to the location of the nerve in this quadrant, an open dissection should always be performed to ensure that the Schanz pins do not wrap up or puncture the nerve. Distally, Schanz pins are placed into the ulnar shaft from lateral to medial with the forearm held in a neutral position. Placement of static external fixator around an elbow dislocation or fracture is required for any neurovascular repair that is performed in order to minimize tension on the repair site. Relative indications for static external fixator placement include continued instability despite medial and lateral ligamentous and bony repair. Hinged external fixators are predicated upon achieving an optimal center of rotation axis, which is located about the center of the capitellum. A fixation wire is placed from lateral to medial with care not to exit the medial cortex as the ulnar nerve is traversing in the cubital tunnel just inferior to the medial epicondyle. The frame is then built around this axis wire. There are many different styles of hinged external fixators as depicted in the pictures shown here. Here is an example of a hinged external fixator placed in static mode with the crossbar limiting elbow range of motion in the immediate postoperative period. Here is an example of a hinged external fixator placed in static mode with a crossbar limiting elbow range of motion in the immediate postoperative period. It is imperative to obtain x-rays at the first postoperative visit to ensure that the elbow joint is still reduced concentrically. The decision can be made if and when to allow range of motion on a case-by-case basis. Generally, the external fixator is removed between 6 to 8 weeks after application. In a static X-fix, forearm pronation and supination and grip strengthening should be started immediately. Once the X-fix is removed, elbow range of motion and strengthening should commence. In a hinged external fixator, active and active assist range of motion can be started early, and graduated strengthening can be started as well, per patient tolerance. In the setting of an elbow fracture dislocation, it is important to distinguish between a transolecranon fracture dislocation and a terrible triad injury. Picture A on the left is an example of a transolecranon fracture dislocation. In this type of fracture, gross instability is due primarily to the loss of the stabilizing effect of the ulnohumeral joint. In this example, there is an associated comminuted complete articular radial head fracture. Repair of the olecranon and replacement of the radial head are likely sufficient to restore elbow stability. Picture B on the right is an example of a terrible triad injury. Here, there is a posterolateral dislocation indicating a rupture of the lateral collateral ligament complex. Also present is a partial articular radial head fracture and a type 1 coronoid fracture. This triad of injuries renders the elbow joint grossly unstable. The typical mechanism for a transolecranon fracture dislocation is a direct fall onto the elbow with an axial load. The humerus is driven directly into the olecranon. Fixation of the olecranon and replacement of the radial head in this case resulted in a stable elbow joint. In the setting of a terrible triad injury, use of an algorithmic approach to fixation results in a straightforward procedure that maximizes efficiency. Similar to pure elbow dislocations that require operative repair, either a midline direct posterior incision with medial and lateral flaps, or two separate lateral and medial incisions can be used. Attention is turned laterally first. After accessing the radial head through either the Coker, Kaplan, or EDC split approach, the decision is made to repair or replace the radial head. If the radial head needs replacement, usually 3 or more fragments, then a radial neck osteotomy should be performed at this point. This improves visualization of the coronoid fracture. If the radial head can be fixed, then the next decision is how to repair the coronoid. If the coronoid fracture can be repaired through the lateral approach, then this should be performed. Type 1 and some type 2 fractures may be too small for screw fixation. In this scenario, suture repair of the anterior capsule with the avulsed coronoid tip can be performed. If the coronoid fracture cannot be repaired through the lateral approach, then the medial approach should be performed to fixate the coronoid with care taken to protect the ulnar nerve, which may be displaced out of the cubital tunnel. Next, the radial head is either replaced or repaired through the lateral approach. Next, the lateral collateral ligament is repaired. Suture anchors work well for this repair. At this point, stability of the elbow is assessed. If the elbow continues to be unstable, then repair of the medial ulnar collateral ligament should be performed. Again, elbow stability is assessed. If the elbow continues to be unstable, then an external fixator should be applied. Here, A posterior skin incision with a lateral flap is raised. The Coker interval is used to access the radial head. The retractors are placed into the joint space across the joint to visualize the coronoid fracture, which is not visible in these pictures. In picture A on the left, there is a partial articular fracture of the radial head, and in picture B on the right, there is a complete articular fracture of the radial head, and the radial neck osteotomy has been made. In this example, there is a partial articular fracture of the radial head, and it is left in place. The elbow is subluxed to improve visualization of the coronoid fracture. An ACL drilling guide is used to more accurately drill bone tunnels through the proximal ulna into the coronoid, and a suture repair technique is used to achieve fixation of the fragment, typically type 1 and smaller type 2 fragments. In this partial articular fracture of the radial head, screw fixation of the displaced fragment is performed. Headless screws can be used here and buried below the articular surface, or regular screws can be countersunk. Care should be taken to make sure that the screw ends are not prominent, as they can cause a block of motion if they articulate with the proximal radial-ulnar joint. If plate fixation is chosen for radial head fixation, then the plate should be placed in the safe zone of the radial head, which is the 90-degree arc subtended by the radial styloid and the Lister's tubercle. In this zone, the plate will not protrude into the proximal radial-ulnar joint with pronation or supination. As mentioned previously, radial head replacement should be performed for fractures with 3 or more fragments. To avoid the radial head replacement should be undersized by 2 millimeters. To radiographically assess if the radial head size is adequate, on the AP view there should be symmetry in the joint space at the radial and ulnar aspect of the ulnohumeral joint. Primary repair of the lateral collateral ligament is performed with suture anchors. Side-to-side repair of the interval is performed to add stability. Medial ulnar collateral ligament repair is performed only if the elbow continues to remain unstable. Finally, an external fixator is placed as a last resort if stability cannot be restored after working through each step of the terrible triad fixation algorithm. Terrible triad injuries are notorious for elbow stiffness. Early aggressive range of motion in the immediate postoperative period is paramount. Active and gentle passive range of motion can be started as soon as the patient can tolerate. This should include both flexion extension and pronation supination planes. Graduated strengthening can be initiated at 4 to 6 weeks. At the 6-week follow-up visit, if the patient is demonstrating poor range of motion, then dynamic or static progressive splinting can be initiated. The goal is to achieve at least the functional range of motion, which is 30 degrees extension to 130 degrees flexion. Again, it is important to obtain x-rays at the 2-week and 6-week postoperative visit to evaluate for elbow joint congruity, and serial x-rays should be obtained until fracture healing is ensured. This concludes our talk. Thank you.